Welcome, everyone. I'm Dr. Guillermina Solis, the Program Director of UTEP's Geriatric Workforce Enhancement Program in the Borderland. It's a mouthful, so we call it the WEP. We are one of 44 grantees in the nation through HRSA, whose goal is to prepare future workforce in geriatrics and dementia-driven care, as well as to enhance the care that is already being provided. It is my pleasure to introduce to you in a minute our speaker. We are very delighted to have a consultant with us. So would you give me the next slide, please? So before we begin, we welcome you again, and please enter in the chat your name, the organization that you represent, and what type of health care does your organization deliver or what you're maybe interested in, and what is your interest in age-friendly health system that brought you to this webinar. I would like you to know that this session is being recorded. It will be provided to other persons that may miss it, and as well as we will provide it to others in the future. So if you would do that for us while I introduce our speaker, it would be great. Thank you. Go ahead and Liz, advance. So here is the title of our presentation, but I want to tell you about our beautiful consultant. So Age-Friendly Health System is the title of our presentation. Elise Passy is with the Alzheimer's Association, and she's the Director of Healthcare Systems. She has a master's in public health as well as a master's in education, and she's a certified dementia provider. She is one of our major consultants in the context of Alzheimer's disease, but also expert in age-friendly healthcare systems. She will be assisting some of our organizations here in our community to evaluate as well, to examine where they are in the journey, what step they're in the journey for a recognition age-friendly health system. And she will share with us her pearls as well as statistics that will set the ground for the work that we're about to begin. Without further ado, I turn over the forum to Elise. Thank you, Elise, and welcome to El Paso.
Thank you to Dr. Solis and the team. I have nothing to disclose other than the fact that I am really happy to be with you here today. Let's talk about what our agenda is, our purpose and our objectives. We're going to identify the purpose of age-friendly health systems for adults, the why are we doing it. We're going to understand the origin and introduce the 4M's framework, which is what matters: medication, mentation, and mobility of the age-friendly health system. We're going to discuss the benefits and the qualifying entities. So who can become an age-friendly health system and what is the benefit to you? And what are the levels of age-friendly care and what does it take to achieve the first level? And then we're going to talk about what we're going to do in our in-person seminar, because I am so excited to be coming to El Paso. So let's begin. We're going to identify the purpose of age-friendly. So between 2010 and 2020, there was the largest ever 10-year numeric gain of an increase of 15.5 million people. The next largest 10-year numeric gain was 5.7 million between 1980 and 1990, and that was less than half the size. It's been the largest percentage increase, and it went from 13% to 16.8% of the total population, and this is for individuals 65 and over. Before 2020, it took 50 years from 1960 to 2010 for the older population to get its share of the population as the same number of percentage points. Now, this is, we all know, because boomers are beginning to age starting in 2011, and 1 in 10 Americans will be between the ages of 65 and 74. So that's 5 times. So when we think about the older population, it grew 5 times that of the general population. Of that population, according to this year's 2025 Alzheimer's Facts and Figures, 1 in 3 of those older adults are going to die with dementia. And that's important because that is one of the M's that we're going to be speaking about. So currently, over 7 million individuals in the United States have dementia, and it kills more than breast cancer and prostate cancer combined. And we know that, and we want to talk about what matters to people. Up to 4 in 5 Americans feel optimistic about Alzheimer's and dementia treatments in the next decade. And 92% of them would want medication to slow the progression of Alzheimer's and the following a diagnosis, which means that M of mentation is going to be really important, as well as taking care of what matters. If we look at the population overall, the percentage population changed 6.1%, but in our state, great state of Texas, we increased 14.9%. In Texas, there are 459,300 persons living with dementia, and that is a prevalence rate of 11.9%. It is the 6th leading cause of death in the state, and 22% of hospice patients have a primary diagnosis of dementia. Now, taking care of these individuals are over 1,089,000 caregivers, who they themselves, 56.4%, have chronic health conditions. 23.9% of them suffer from depression, and 16% of them say that they are in poor health, and they are delivering 1.9 billion hours of care. So when we think about this, it's important to understand those who have dementia, those who are caring for them, and that is part of the overarching story of those who are seniors. When we look and we hum down right to El Paso, according to the U.S. Census website, in the 2024, the population of 65 plus in El Paso was 13.9%, and that was an increase of 0.4% over 2023. According to the El Paso County Health Assessment, the chronic health conditions that we're concerned about in your community are obesity, cardiovascular health, diabetes, and hypertension. Those are all priority needs, and we know that those are all risks for dementia. 15% of adults 65 plus are estimated to have dementia, according to a 2024 prevalence study. Now, that is one of the highest in the country. So when you look at our map, you guys are pretty red. And so we want to account for those patients throughout the care continuum. So how does this all relate to age-friendly care? So the age-friendly care movement was started by the Institute for Healthcare Improvement. And it was started because of 3 main reasons. One, demography. As we talked about, the number of older adults age 65 is doubling and projected to be 25 in the next 25 years, double that of the population. And because that demography, and we talked about what it looks like in El Paso, accounting for all of the following M's is going to be important for caring for those individuals. The complexity for seniors is also greater. 80% of older adults have at least one of those chronic conditions that we talked about. 77% of them have more than one. If we look at the graph to the right, we see that the number of adults is expected to climb above those under age 18. So that they would then make up a greater portion of our healthcare population. So what's the mission of age-friendly care? It's to build a movement of care for all older adults. It's guided by a set of guiding principles, the 4 M's: what matters most, medication, mentation, and mobility. It seeks to cause no harm and it is consistent with what matters to the older adult and their family. In other words, this is a shift to person-centered care. What does the older individual want? Not necessarily what does their family want or what is best for the clinician, but what is important to that older adult. Now, this movement has grown some great momentum. There are over 5,211 sites of care that have been recognized, and it is actually faster than they originally anticipated. So why does it work? Well, it is a sticky framework that resonates across multiple disciplines and settings, and it is easy to focus on system-wide spread, meaning we can start in one small unit and expand it throughout the care ecosystem. It simplifies complexity. We were able to see this during COVID-19. Communities of improvers are focused on learning. This is a communal experience. This increases communication between care providers and provides a framework for that discussion. And there's learning that is being gleaned from across the movement, and it has actually led to informing regulation and policies, so much so that the Center for Medicare and Medicaid is now asking for inpatient hospitals to attest that they are providing age-friendly care. So let's dive into each of those M's. We talked about the fact that there is medication, mobility, mentation, and what matters most. And what's not listed here is malnutrition. This M is been added because we know that it affects all of the other M's. Now, M's do not work in a silo, but rather they're connected one to another, and they influence the care across the care continuum. Now, we know that the real driver of all of the M's is what matters most, but I always like to start where everybody can feel successful and say, I do that. I'm thinking about that already. So we're going to start with medication. The goal of the medication M is to review patient medications to identify any potential harm or drug interactions. Also, to ensure that all medications are actually beneficial and that the medications do not interfere with what matters most, mentation and mobility. As I said, these all work together. So what do? We review all the medications. We identify and document high risk and potentially inappropriate medication uses. We deprescribe opioids. We understand that there may be other medications that we can use to provide our patients as opposed to these drugs. We look at all prescriptions, even the over-the-counter ones and the sleep medications, muscle relaxants, mood stabilizers, because we want to make sure that the medication that our seniors are being given are not only are appropriate for what the senior needs, but are also the appropriate dose, because we know that seniors metabolize medication differently than your average 50-year-old or 30-year-old, or certainly a 20-year-old. Our next STEM is mobility. Mobility is to ensure that older adults move safely every day to maintain function and do what they want to do. You can see in the do what they want to do that directly impacts the what matters most to them. If you can't move and what matters most to you is the ability to garden, then we want to make sure that that patient has the opportunity, or that we work with them for the ability for them to be able to garden. So how do we assess mobility in the setting? Are we using a validated tool? Are we able to compare the mobility from this time to the last time? We want to mobilize 3 times a day or directed by a clinical team. And we want to do things to help facilitate the patient getting out of bed or leaving the room for meals, therapy, or activities. We want to we want to initiate physical therapy interventions if appropriate. We want to make sure that the living space that individuals are living in are free and clear so that individuals can walk safely in their own domain. Now, this is a big M, the M of mentation, mind and mood. Included in this M are what we call the 3 Ds: dementia, depression, delirium. And we want to make sure that we are looking at this across all settings. Dementia is not traditionally diagnosed in the inpatient setting, and in many inpatient settings have what we would call a delirium protocol in place. What do they do to prevent delirium, or if an individual has delirium, what is put in place to ensure and to alleviate the delirium? So let's be clear what dementia is. It's an umbrella term for the loss of memory and other thinking abilities, severe enough that it interferes with daily life. Types of dementia are Alzheimer's, vascular, Lewy body, frontal temporal, and other dementias such as Huntington's. Though Alzheimer's is the most common form of dementia, mixed dementia also accounts for a large percentage of dementia. Mixed dementia includes more than one cause, so Alzheimer's as well as vascular dementia. Please feel free to stop me or put your hand up if you have any questions. So that's the dementia. Depression. Texas ranks 8th for senior depression. It's got a prevalence rate of 12.9%, and 80% of those who experience depression have a treatable condition. So making sure that patients fill out a PHQ-9 when they go to the clinician, and many of us already do that when we go to the doctor, is one of the ways that we screen for depression. Screening for delirium is also important. It is usually done in an inpatient setting at least every 12 hours, and those results are usually documented. Ways to alleviate delirium: ensure sufficient oral hydration, orient the individual in time, place, and situation, validation and orienting cues if they have dementia, and ensure that older adults have personal adaptive equipment such as glasses or hearing aids. Avoiding high-risk medications that may cause delirium. Sleep is incredibly important to prevent delirium. So we want to prevent sleep interruptions and use non-pharmacological interventions to support sleep, which is setting lights, making sure it's quiet. We want to make sure that ways to treat delirium with hydration, safe mobility, good sleep practice, following the best practice guidelines, including avoiding those medications if they're not approved. And we know that age-friendly health systems help with delirium. So delirium is onset. It occurs within a short time, in a day or two. Its inability to stay focused is impaired, and symptoms come and go. So if we want to look and compare dementia and delirium. So dementia mostly occurs in older patients. It's a neurological disease with a variety of subtypes, as we talked about. It progresses slowly over months to years. It is a slow progression. It is a more consistent and chronic progression. And it is characterized as a cognitive deterioration interfering with one or more areas. Delirium, on the other hand, is a process that happens to people of any age and is more common in older individuals, though it can happen for a variety of reasons. It usually happens within an hour or days. It's an acute confusional state that fluctuates and evolves over days to weeks and is likely to be delirium. Delirium is characterized by altered awareness, primarily impaired attention. Patients with dementia are more prone to get delirium in an inpatient setting. What matters most? Many find that what matters most is the most difficult of the M's for healthcare settings to start. So what is what matters most? Well, we want to know and align the care with each adult's specific healthcare outcome goals and care preference. And this is included but not limited to end of life care, and it's across all settings. So it's not what do I want to do at this visit, but rather who am I? What is important to me as a person? And how what is important to me as a person, and you can see from these slides. So what may be important to me as a person, maybe I like to garden and I want to be in nature. And no matter what's going on in my life, I want to be around nature. So I want my care to be guided by the opportunity to be able to do that. That's important because it helps the nursing leadership or the nurses or my doctors to decide what care is appropriate to me, or making sure that being outside is probably going to be key to me being successful in my plan of care. My grandchildren may be the most important thing to me. And that may be motivating to me to move because I want to take my grandchild to school. And so I may be willing to do physical therapy if it means that I can now go to school, take my grandchild to school. There may be things that I may not be willing to do, but that's a motivator for me as a person. My faith, going to church, being able to be around my community is very important to me as a person. Documenting what matters most to an individual allows the care team to align and provide care to them based on what matters to them. What matters to me may not matter to you. But what happens is we're able to then make sure that the family knows what matters, the clinician knows what matters, the OT and the PT, and we're all working towards goals that are important to me as an individual or your patient as an individual. Giving patients an opportunity to share their fears and concerns about their health and about being in the hospital help to tailor treatment and education and help to address concerns. So sometimes that question may be, what concerns you most when you think about your health, including your cancer or what treatment? Or maybe the question is, what fears and worries do you have about your health, including your memory? What do you want most from being in the hospital at this day? Or what would you like most to be able to accomplish at this visit? All of those put the person in the center of the conversation and helps to guide the care. For old adults with advanced or serious illness, what are your most important goals if your situation were to worsen? Having that information from the individual allows the care team to then look at, okay, how are we going to look at the medications that we give this patient? How are we going to address depression, delirium, dementia? How does this affect their mobility? Altogether, this M, the what matters most, helps to drive all of the other M's and helps to make sure that we are keeping the patient in the center of the conversation. And that M should also continue throughout the care continuum. So if I am a patient, a senior patient, and I'm in an inpatient setting, then when I'm discharged and I go back to my primary care doctor, what I've said or what I've addressed should then be conferred back to my primary care doctor, or the converse. In talking with my primary care doctor, I have said what's most important to me is that I live pain-free and I'm at home. So those goals of care should be taken into consideration as to whether or not a hospital visit takes place, whether or not that person is given life-saving treatment. What is important to that person? Does that person just want to be maintained comfortable and be able to be surrounded by family or friends? Or do they want to do whatever it takes because they want to be able to be part of their family for as long as possible? Hearing that patient's voice will help us with all of the other M's. So let's talk about, from the health system's point of view, because we've talked about how the 4Ms benefit the person, right? In person-centered care. How does this benefit the health system? So when we think of the quintuple aim, and that's a framework that's built on what we call the triple aim and the quadruple aim, and this is the focus of care, we're talking about 5 key areas: enhancing the patient experience or improving the patient experience, improving population health or better outcomes, health outcomes. We're lowering the cost of care. And then we've added these other 2, clinician well-being, as well as advancing health equity. Putting the patient's voice first allows us to enhance the patient experience. A quote from one of the patients whose mother had experienced age-friendly care: "You guys have given me my mother back, the daughter of an older adult, after seeing the impact of the mobility coaching and the Move and Groove program that was part of the 4M's care at the University of Alabama Hospital. Patients feel like they matter." Better outcomes. Enhanced coordinated care provides better outcomes. Lower costs. There may be costs to ensuring documenting in the EHR, but the benefit calculator shows that overall spending is reduced. It reduces readmission rates, length of stay, allows individuals to stay in their home, which is more cost effective. Clinician well-being. So nurses say that screening or using the 4Ms is so powerful in finding patients who may benefit from geriatric principles. Nurses report that they feel better connected to their patients and able to help them achieve their health goals. And this is a type of care that can be delivered to everyone. So that addresses health equity. If we look at the financial benefits of becoming age-friendly, we can look from a business case: avoiding costs of poor quality of care. Age-friendly health systems reduce cost in part by reducing poor quality medical care. Cost avoidance stems principally from the reduction in incidence, duration, and acuity of hospital and post-acute care, as well as readmissions and emergency room visits. And we know that patients with dementia end up in the hospital 1.5 times more likely. So being able to have patient-centered care allows us to be able to address those patients because we've addressed that M. We look at deliver care in cost-effective manner. Age-friendly health systems can prosper financially by providing the right goal concordant care in the right place at the right way. So, for example, intensive ambulatory care in the home for a high-need older adult can substitute for a more costly emergency room visit. Inquiring into what matters may result in fewer days in an intensive care unit, less specialty care, and more palliative care. Or simple and inexpensive hydration, mobilization, and reorientation activities can replace less effective and more expensive antipsychotics in managing delirium. Enhancing revenue from high quality care and age-friendly health system can augment revenue by increasing the number of appropriate encounters and intervention. One source of potential revenue is the annual Medicare annual wellness visit and resulting encounters such as advanced care planning and health screenings. Revenues can be augmented too through the quality improvement that characterizes age-friendly care. First, such care improves the patient experience, which positively influences survey results for the Consumer Assessment of Healthcare Providers and Systems, or CCAPS, or hospital HCAPS. It improves survey scores and may insist in meeting quality improvement standards imposed by CMS, the Center for Medicare and Medicaid, or health plans. Second, valuing enhanced care may lead to improved reputation and increased market share. Shared savings and other arrangements designed to reward improvements of quality care are increasingly common, such as accountable care organizations, and create further opportunities for bolstering revenues. Finally, age-friendly care can lead to fewer hospital admissions and readmissions and reduced lengths of stay. Capacity then can be released and beds back to filled by other revenue-generating patients if such a demand is available. So you can see there are many different ways that health systems can benefit from age-friendly care in a financial way. We also see, and we talked about, that what matters most can help unwanted ICU care in the hospital. Medication, adverse drug events are quality. Mentation, reduction in delirium. Mobility, injuries and falls, pressure stores, and venous thrombolism are all the adverse events that can be helped through age-family care. So the Institute for Healthcare Improvement knows that one size doesn't fit all. And so there are different care settings and there are different applications for different care settings. So there's these are the different kind of age-friendly care settings that can apply for recognition. Hospitals, nursing homes, ambulatory care, convenient care clinics, home health. There's a special opportunity for hospitals that have achieved geriatric surgery verification and sites that have achieved geriatric emergency accreditation. So what are the levels of age-friendly care? And what do you need to do to start? So the recognition from IHI falls into two categories. The first category is a participant. And this means that you're on the road, that you're committed to making changes and to be providing that care. So that's open to hospitals, practices, convenient care clinics, nurses' home, all the area care settings that we talked about. And the second is all of the same people who have received level 1, but they have actually been looking at their care and submit data for patients who have received that care for at least 3 months. And that is considered committed to care excellence. So what does it take to get to level 1? So the first thing is we need to understand our current state. One, which care setting model are we looking at? Are you going to apply for? Who is 65 plus in your care setting? What do those numbers look like? Who are they? Who is involved in the care of these patients? Then we want to set up a team and set an aim for that team and review the current state. Want to identify opportunities where you need to design or adapt care to meet the 4Ms. So you may already be doing medication reconciliations. You may already have the PHQ-9 in place for depression, and you're already screening at annual wellness for dementia. But you may not be really specifically asking patients and documenting what matters most. So that may be an opportunity where we need to design and adapt care to meet the 4Ms. Or you may say, you know what, we don't really, we do look at medication, but we don't have a specific place where this is documented or how we're actually doing this. So you're going to identify your opportunities for improvement and you're going to design or adapt care accordingly. And we can work with you to do that. And then you're going to implement those changes. And then once you believe that you're providing care consistent with the 4Ms, and that's by just studying your performance, you're going to complete an email or mail in the application. What we know is that care sites are the most successful in getting to level 1 and especially getting to level 2 if they also identify a clinical champion leader. So not only is there a group or a team that's working on it, but there's somebody in leadership who is sponsoring this team to be able to make this happen. Start thinking about how the 4Ms look currently in your care setting.
Great. Thank you, Elise. Let me remind you that all our resources are free. You're and they are available for you by contacting us. We will have a recording of this if you want to share it with the rest of your team in your workplace or your families. And we also have many educational resources because of the grant and the tremendous work that our team has done. And I cannot leave this forum without introducing a couple of people from our team that are here that are key to our success. And that is Maria Llamas, who is a program manager, and you hear quite a bit from her. And then we also have Marcos Garay. He is the assistant to Maria and is behind the scenes with a lot of the mass media as well as the electronic resources that we use. We have much more in storage for you. We will be meeting with UMC personnel on the 27th, with Elise being among us. And we continue to grow to bring the best possible resources and the most updated in geriatric care, as well as enticing future generations to join the world of geriatrics for caring for that population. I have no problem. I already joined geriatrics by age, but I would love for others to be informed so that when my time comes and my loved ones' time comes, they will be prepared to care for them. So without further ado, if there are no other questions, we will go ahead and sign off.